afternoon. Good afternoon. Good afternoon. We bring you greetings from Richmond Media Health Issues to everyone and everyone listening and watching us. We are bringing health to your doorsteps. Therefore, we want to remind ourselves that it's time and it's time for our health discussion, health issues. Beloved, the groundwork of all happiness is to have good health. And you can only attain good health when you have good knowledge and practicing the knowledge that you have gained. That will alone help you to have good health. That's why Richmond Media, we are saying that our viewers and our listeners, you are at our heart. Therefore, anything concerning health, the angles, the issues is coming from. We want to bring you a required, prescribed professionals who will come so that we discuss for you to get the knowledge and you will be able to have a better health. Therefore, today is a special day. Today is really, really a special day. We have a nice topic that we want to discuss. At the same time, we have to give some people hope, and some people also have knowledge about the steps that they want to also undertake. After God created human beings, our duty was to give birth and continue creation. But as part of this process, there are some things that are also being linked to. So today we are going to talk about something that we call prematurity. And we will be going through the management of this prematurity. What at all is prematurity? Our guests will help us to be able to understand it. When we talk about prematurity, what is it? How does it affect individual? And we will be able to dive deeper to it. So today with me is our special guest who is into this field. And when we come to talk about anything concerning children, anything concerning the health of these things, is one of the best to consult. So we invite Mr. John Anaba to Richmond Media Health Issues this afternoon. Mr. Anaba, good afternoon.
Good afternoon, Mr. George.
Yeah, you are welcome to Richmond Media Health Issues.
Thank you, and it's an opportunity to be here and to share the little we have to help society in the health sector.
Okay, thank you. Beloved, if today is your first time of watching Richmond Media Health Issues, we want to encourage you to subscribe so that anytime we are having this effective discussion like this, you also be the first to get in touch with it. And also invite friends to also join this discussion, because if it's not up to you, you might be in your menopause, but you might be having children, you might be having other people around you, then we can go deeper into it. But before the main presentation, what is special about today that you will let us know before we get into the topic? What is special about today?
Yes, so today happens to be the birthday for every preterm. So today, 17th November, every year, we happen to commemorate the Prematurity Day. So worldwide, today activities are being held elsewhere in the world, and even Ghana as a whole, and even my facility, to create the awareness about premature birth, the challenges it comes with, how we can get over those challenges, and even prevent it from happening at all. So today happens to be a special day, 17th November, World Prematurity Day, 2024.
Wow. Then our guest is trying to let us know that our viewers and listeners for today, you are special, because programs like this, you need to visit a higher place to sit down before you can even listen to us. But we have just bring this thing to your doorstep. Thank you. But what's the theme for this year's prematurity or World Prematurity Day?
Yes, so the team, every year we try to look at one aspect of the challenges premature births face, and we try to hammer more on it. So this year, we are talking about over 130 lakhs baby born too soon every year, access to quality care everywhere. So when you look at lax, it's a French
Okay.
word. So 110,000 babies born every year too soon. And at the end of the day, they face a lot of issues with their health. So how do we get them access to quality care so that wherever that baby is born, whether in the village or even in a big city, they will still be able to get the required care that they need to survive till God calls them someday.
Okay, thank you. Then it's very interesting and very nice topic that we want to share with you. I hope as part of the presentations, this is not an abstract, it's a real presentation. I'll tell you, our viewer and our listeners, that Mr. Anaba is into this field. So we are bringing you rare stories, but we will dive into it deeper. And as he will tell us more, how were you able to get some of the information? And we know that you will tell us more about how you were able to get the information from some of our clients.
Yes, so putting this information together for this presentation, uh, I think with my years of experience in taking care of babies and children for that matter, I've come across a lot of mothers who have had these preterm births. I've nursed and we've gotten success stories from a lot of them. So putting up these slides, I needed to bring out those practical experience and then those stories that would be worth sharing. And that I think I acknowledge them because sharing their images on platforms like this should be well, adhered to because it is necessary you gain consent before you do whatever you do.
Thank you. So, a viewer who is watching us, we want you to also be part of these success stories and you also get testimonies of it. So, Mr. Anaba, what should we expect in today's presentation?
Yes, so for the purpose of this education, we want to generally look at how premature birth is, what it is about, why we should be worried a bit about it, and what actions we should take. We will look at the specific causes of preterm birth. How do we manage them? That is the most important thing because bringing out a baby who is not fully matured and then trying to navigate through this our system becomes a bit challenging. The complications they do have and how to prevent such. We would also look at if your baby is preterm and is on admission, what is the criteria that the doctors, the health professionals should be looking at before they can say, okay, you are able to go home and continue treatment. And then we will conclude with some images and we'll share the stories that are worth sharing. Our references are also there for to prevent plagiarism.
Thank you, thank you. So, we know that how even the outline has been given, it tells you that we want to give information to a layman. We want to give you information to some health workers who are in the field. So Mr. Anaba has just given us a lay down for us to have a comprehensive lesson so that me as a layman, you as a health worker, you have a part to play. So please, can you take us through the overview of prematurity?
Okay, so when we talk about premature birth or prematurity, WHO defines it as birth that occurs before 37 completed weeks gestation. You know, usually every pregnant woman should have pregnancy up to 37 weeks. Usually, in the layman's perspective, we say 9 months. So if your pregnancy doesn't reach 37 completed weeks, it means that you have given birth to a premature baby. And when you count in days, about 280 days is what usually is important, that by then your baby should have fully matured and given birth. But usually those that come earlier before those days, the premature birth, they are also classified in with regards to which weeks they are born. So usually we have the extremely preterm, those who are born with before 28 weeks gestation. one fact is that usually in health care settings where there are no uh, advanced machines to care for these babies, usually they don't do well. And Ghana here, below 28 weeks, I think usually we term them as abortions. So it doesn't really count because of how they come and then the kind of care they need, but we don't have the logistics to do. But I can tell you, in my facility, we have nursed babies that are born 26, 27 weeks, and they've fully grown now with our full hours that we've done. We also have the very preterm. That those are 28 weeks to less than 32 weeks gestation, and then we have the moderate, usually 32 to 34, and then the late preterm, which is about 34 up to 36 weeks gestation. So when you categorize them, each of them, they come with specific problems that usually you need to be so much interested in and in managing them. That's why this classification is very important.
Okay, thank you. Because most people think that the moment you get pregnant, anytime you can give birth or anytime baby can come out, but not knowing that the day that the baby will come out will help us to know the classification that we will fall, the person will fall under. And you said you have your facility have been able to nurse less than even 26.
Yes,
Yeah, please, which facility is that? And the
that's
locality also,
okay.
the
Margaret
country.
Magwa Catholic Hospital in the Bosa region, Pando to be specific. Uh,
Okay.
yeah,
Then God bless you and your team for this successful and the success work. And I know our viewers will also appreciate that. So
thank
after
you.
knowing the overview of it, can you please tell us about the epidemiology of this condition?
Yes, so epidemiology, just to tell how serious is the issue or what is the distribution of this premature birth. WHO estimates that over 50 million babies are born too early every year. So when you look at the worldwide coverage, about 50 million. In 2020 alone, about 13.4 million were born in 2020. And when you do the ratios, it's just like in every 10 pregnancies, you get one pregnancy that is giving birth to a preterm baby. So when you take 100, it means 10 babies to a preterm. Usually, these preterms we said come with a lot of issues, and one of them is about the complications. So, approximately about 1 million children um, had kind of deaths, mortalities related to the complications that come with preterm birth. Most of the survivors usually have disability in their lifelong, in the long term. And some of these disabilities, usually learning disabilities, some are visual and hearing problems. But when you come down to the sub-Saharan Africa and then South Asia, we account for almost 81% of these preterm births. And it means that we, the less resource countries, we are giving birth to babies that need complex care. And it's something that we should actually be worried about. When you come to Ghana, approximately 128,000 babies every year, and when you look at this number, 8,400 children under 5 die due to the complications of preterm that they suffer. There is also an increasing trend. When you look at some statistics or evidence-based publications that were done at Kolebu, some were 2003 to 2020, 2019, about an increase of 18.9 from 9.3% was seen over this year period. When you look at Cape Coast Teaching Hospital, about 4.7 percent over a 10-year period. And then when they did their review in 2019, about 9% increase. So when you look at the trend of premature birth, it is increasing instead of it to be declining, so that we'll be happy that, okay, now our mothers are giving birth to full-term babies, so there's nothing much to do. The incidence is rather increasing, and once the trend is increasing, it means that we have a lot of increasing problems to deal with when it comes to our newborn births. So I did a small DIM search in my facility data, I think somewhere 2020, 2021, while we were preparing to celebrate this preterm birth. We saw that about a total of 1,565 and 1,302 were delivered in 2020 and 2021 respectively. So when you look at this, out of these births, about 1.4% increment from the previous year, 2020. So 2020 we had 98 preterm births, and 2021 we had 100 preterm births. So when you do the percentage calculation, that's about 1.4% increase. When we looked at the mortalities, it stands at 2.1% and 1% for the above 2 years that I mentioned about. We also, because we had no much machines to manage such cases. One thing is referral. So we had to refer 16.3% of our babies in 2020 and then 6% in 2021 so that they could get the much needed care that they needed at the teaching hospital. Usually, we try to aggregate our figures from 2020 to 2022. When you looked at our delivery data, about 277 admissions. These were a 3-year period for preterms, 23 referrals, 7 deaths, and then we had about 247 discharges. So when you look at the percentage of mortalities, aggregate of the number of the 3-year period, I think we wouldn't say we are doing so well, but I think we've done well with the limited resources we have in our facility while managing these complex problems these babies come with.
Thank you. Then I think, as you said, now the condition is increasing, or this prematurity thing is increasing, and how we are seeing it from your speech, we have seen that then it means your facility, if they could have had some resources to help a lot, there would have been some good management than how you are seeing it. So there are some challenges, and I know
Absolutely.
viewers and our listeners, let's keep this in mind. When we have the resources, children can survive. So I know at the end of this presentation, there will be a way out so that we can also help how we our viewers and our listeners can also support in some of the things that we can put on board. Thank you. So now that is increasing, what are some of the risk factors and the causes that is contributing to this increase in prematurity?
Yeah, so usually the risk factors are many, and the simplest thing to do is to categorize them. Risk factors related to the baby or causes related to the baby, I mean, while in utero, and then the placenta, the uterus, the mother herself, and then if there are any obstetric reasons. So when you look at the fetal causes, when a baby start having distress before it's 37 weeks, fetal distress is something that should make a C-section a very best recommendation. So you would definitely want to bring the baby out before the baby is matured, because when you don't bring a baby that is in distress out, the distress alone can kill them even in utero. So it's better to bring out and manage than to leave them to die in utero. Usually some of these babies have genetic disorders, just like the trisomy 21, the Down syndromes, and I mean those County-Ferret syndrome. Because of the genetic abnormality or inheritance, that makes them try not to thrive well in utero. So usually the best thing the body can do is to expel it out while not mature, so that each of them will have a peace of mind, just to say. And when you look at the placenta causes, usually some of the placentas, they are attached at a place that are not supposed to be. So we call it placenta previa. So when you have a placenta attaching to the cervical os, okay, then it means that there's a birth complication because of bleeding. That's always common with them, and this baby can come out before its maturity. We also have placenta abruption. Usually, placentas are supposed to detach after the baby is born so that the placenta can be delivered. But when you have your placenta detaching from its, I mean, the uterus earlier before the baby is mature, then you can have issues with premature birth. For the uterine causes, we have biconate uterus and then incompetent cervix. There are some people, the shape of the uterus, the cervix also is not that strong to hold the developing fetus when the weight start bearing on it. So you kind of have to come out preterm. Maternal causes anemia. You have low hemoglobin levels. Okay, it can make you give birth early before your usual time. The fact is that the baby depends on the mother for everything, nutrients and oxygen. So once the mother um, low HB is not able to get the mother supply the baby so much as needed, then the baby will definitely come off early. Recently, one mother had to deliver preterm because of malaria infection. So other infections are very common, especially during pregnancy, and when that happens, the mother can deliver prematurely. Sometimes some mothers have chronic illness, something like sickle cell disease and other stuff. Okay, diabetes, hypertension, and those stuff, they can all, I mean, cause be a cause for preterm birth. Obstetric, I mean, complications like the premature rupture of the membranes. The membranes are what cushions the baby, and give, I mean, protects the baby in utero. So when it ruptures so early, then it means that labor can start at any time. Then because of some hormonal issues, then the baby will come out preterm. Iatrogenic and preterm labor, multiple pregnancy, preeclampsia, all these are I mean obstetric issues that when they happen, the baby would be delivered preterm. Now, those were the causes I mentioned about, but usually there are some predisposition that can make these causes now pronounced. So, assuming a mother who is less than 19 years, so I mean, teenagers, and I think for the last 2 months, we've happened to had a lot of teenage mothers admitting here, which it's in itself is a problem. So teenage pregnancy is one of the reasons why a mother can deliver preterm. An extreme, I mean, old age, those who are above 35 years, usually the risk is high that they will definitely give birth to a preterm. Not that much though, but most of them also come with these issues. Then if someone had a previous history of a preterm delivery, maybe your first, second, or third born was a preterm, the likelihood that you would deliver preterm on your fourth pregnancy is very high. When you have multiple pregnancies, maybe twin gestation, triplets, quadruplets, how many you are incubating can make you deliver a preterm. Lesser than 6 months gap between pregnancies. Those who get pregnant while the other baby is still breastfeeding, they get pregnant again. The likelihood that you give birth early is very high. Those who did in vitro fertilization, artificial insemination, it's one of the risk factors. Smoking, alcohol intake, and other substances. Once you take in those ones, your body would definitely try to behave some way that can make you give birth preterm. Urinary tract infections I mentioned earlier, and or other vaginal infections. When you have high blood pressure or diabetes, your weight is not balanced, overweight or underweight. If you have history of miscarriages, and then physical trauma, assuming someone gives a blow to your gravid stomach. At the end of the day, it can affect the baby, and preterm birth is inevitable. And we had one evidence coming through our wards recently. And there's also stress. When you are overstressed, usually your hormonal imbalances alone can make the body to expel the baby preterm. So, in short, these are some of the causes and risk factors.
I think we can continue with the health problems.
Yes, so the main issue about preterm birth is the health problems they come with. The fact is that the person is not matured. So everything, almost everything about the baby's system is not matured. And these problems are what would definitely get this baby to die too early or have the complications that will make his or her later life not that of the best. So we kind of want to look them through system by system. The respiratory system, when you look at them, most of them they come with respiratory distress syndrome, usually because their respiratory tract is not, respiratory system is not well developed. They have apneas of prematurity. They breathe stop for a long time before they breathe again. Some usually have pneumonias and pneumothorax. So these are health problems specific to the respiratory system. The gastrointestinal system, we have necrotizing enterocolitis because the gut is not well developed, and especially when you have extreme preterms that have started feeding too early. Whatever work the GIT was supposed to do, it will not be able to, actively digest and absorb food. And you see that, let me just say, the intestines will start rotting small, small from somewhere. And at the end of the day, you get all the GI, what do you call it? I mean, gangrenous or whatever, so that the baby will not be able to survive. We also have feeding problems because their gut reflex, their sac reflex are not well matured. It happens that they may not be able to suck, or even swallowing might be difficult for them. So they will definitely have feeding issues. Cardiovascular, you look at the heart, usually God has made the heart in such a way that while in utero, blood doesn't go to the lungs for reoxygenation because the baby is not breathing by itself. So we have the patent ductus arteriosus opening to make sure that in utero the baby gets, oxygenated blood. But when it comes out, that is supposed to close. But because this baby is not mature, usually this ductus still remains open, and it will be a heart problem for them as they come out of utero. Bradycardia, their hearts will be beating so low, so the body will not be able to get oxygen or nutrients to all the peripheral parts of the body. Hypotension is one of them, and these are some of the common cardiovascular problems that they face. Immunologically, they are not able to prevent or fight infections because of their immature immune system. So usually they are susceptible to infections. Okay, and once they get these infections, then they get septicemic and kind of go through that process and never may return. Neurologically, when you want to look at the nervous system, usually they will have intraventricular hemorrhages in between the ventricles of the brain. Okay, the capillaries or those blood networks, they are not well matured, so they get to bleed into the ventricles and can have issues. Seizures is one of them, and hypoxic ischemic encephalopathy. Once their brain is not getting enough oxygen, then they can go into this state. Metabolically, you see that they become hypoxic because they are not able to reoxygenate the blood so well because of the immature respiratory system. Then they can't control their temperature because their fat layer is very thin, so they are not able to what do you call it? Um, get much of the insulation that they need, and their thermoregulation center in the brain is not that developed. So they tend to not be able to regulate their temperatures well. Then hypoglycemia and jaundice because of excessive breakdown of red blood cells that are not processed to be taken off the body. So commonly they have these problems happening through their lifetime. Now, those were the short-term life events. What of long-term? If these babies survive in the long term, what would they face? One common thing is cerebral palsy, that you have a preterm birth that had to be able to navigate through these tedious days of its, life, coming out with a lot of issues. Then when they grow, they are not able to one sit at the time. There are other kids that are sitting. They are not able to learn. They are not able to. At least they will be having those pauses that will cause their developmental delays. Serious disorders are common, and delayed development, especially learning difficulties. Then in school, everybody is scoring A, but that child would not be able to pick up in class. Retinopathy of prematurity, usually because their respiratory issues, you give them oxygen, and once you are giving them oxygen, one of the complications they will develop is the retinopathy. And then bronchopulmonary dysplasia, we said the respiratory tract is not well developed and it becomes hyperactive, and then the lining becomes a bit changed, and they have persistent issues with their respiration whenever they are grow. So most of the times you see them coming back with issues of breathing difficulty and other chest syndrome and other stuff. Then recurrent wheezing, usually because of respiratory infections, and hearing impairment. They are Then malnutrition is one common thing that we see, because at the end of the day, this baby has has feeding problems at birth, and if that is not well managed, then in the long term they will always come with malnutrition, and it's something we've been seeing once a while here. Now, enough about talking about their problems, right?
Yeah. So we now know how serious this this can be. And no wonder that everywhere, as you are saying today, they've been given opportunities and they are celebrating this for the success stories. At the same time, we are working on how to educate people on these risk factors. So God bless you on how you have taken your time teaching our viewers and our listeners on these risk factors. This explains why it is increasing. So when we are able to correct from there errors, the risk factors, the causes, I hope we can be able to reduce the increased trending. So with this, what are some of the management options? How can we manage this condition? Thank you.
Yes, so after knowing the problems they will come with, or they come with, the good thing to do is to know how to manage them. So we will want to take each of the problems one after the other and see how we can deal with them as we go along. So our focus usually in the NICU is to make sure that they have good thermal control, like their temperatures, you are able to keep them in check within acceptable ranges, so that they would not have hypothermias or hyperthermias. Then also oxygen therapy is very important, because we mentioned that they have issues with their respiration. So usually you'd want to help with oxygen therapy until such a time that they are able to do well on their own. And monitoring is very important, because before you can take any action or you identify any impending short-term complication or long-term complication, is from your vitals, your basic vitals, and the other hematological monitoring that, or hemodynamics that you'll be checking. Usually, fluids is very important, and you would need to manage them based on their fluid requirements per day. And at the end of the day, you will not get issues with malnutrition or dehydration or hypotension. Special attention also is on the feeding. Feeding is very important, and infection control. Infection control, I like it because I happen to be an infection control advocate or resource person. So usually in the NICUs, you see us having a lot of trouble with visitors and other stuff. So once we go over each of these things, we'll be able to grasp much importantly what we are supposed to do.
Okay, so before we enter into deeper, then it means this category of babies are not like the other babies that they will deliver them today, then tomorrow they are sent home, right?
Yes, yes, absolutely. So
Okay,
every preterm birth may have to pass through the NICU, because if it's a late preterm and the baby is fine, you might want to teach the mother what to do at home and then they go. But once it's moderate or very preterm or extreme preterm, then they must pass through the NICU to make sure that everything is okay before you can discharge them. And at the end
so
of
we,
the
we
day,
yeah, we want to create the awareness to the husbands and other family members who are saying, oh, because baby is out, let's go home. But
yes,
the
yes.
prescribers or the health team knows why they are sending that baby from the mother to different units. Thank you. So we can
Yeah.
now dive deeper to the management. Thank you.
Okay. Yeah, so the thermal control I spoke about, we want to maintain a temperature between 36.5 to 37 degrees Celsius. So what we do mostly, you can use the incubators or the radiant warmers. So these are machines specially designed to be set at certain temperatures. So you can regulate the temperature as and when you want or what range you want. So if you happen to have an incubator or a radiant warmer in your NICU, then you definitely would be using one of them to keep them warm. Others, cost effective, we have the bulb, the onion bulb. It's a modified form of the radiant warmer. So the onion bulbs have some level of heat when they are switched on. So I think here I should have picked a picture and then because I have some in my NICU here. So at the end of the day, that onion bulb over a flat surface, a cut or something that the baby will be on can provide the required heat. Usually, when you are transferring a preterm to another facility, and you can't use the incubator and transport, you can't use the radiant warmer and transport. The best thing to do is to use a polythene bag. Okay, keep the baby in the polythene bag, but make sure you don't cover the baby's face or you
That's
can
what
cover.
I wanted to ask. Oh. That's what I
Yes.
wanted to ask. So
Oh,
that
no.
someone will not go and put a baby in the policy bag and just tie.
Yeah. So you can use the polythene bag to wrap the baby, but not cover the face, the nose, or the mouth, please. You just have to leave those places open so that the baby can still breathe. There is this foil, the one that we use to seal our food when we are in public and want to serve. You can also use that kind of foil to wrap the baby while you are transiting. Usually, you would want to maintain a humidity between 40 to 60%, whether in the incubator or in the NICU or the ward that you are managing these babies. Approximate nursery environment is very important. You should be able to make sure that all your louvers are closed, your temperature is not so cold in the NICUs or in the room, and there is no draft, okay, so that you be able to maintain a good nursery environment for them. Continuous monitoring the temperature, that would inform you as to whether you are achieving something or you need to up some stuff. Now, one thing about thermal control is what do you call it? KC. Okay, so we'll be speaking specifically about KC when I get to that portion. But remember, skin to skin with the baby can also give a good thermal control. That will be when the baby is okay and is off oxygen, and I mean, it's not under phototherapy or other stuff. Yeah. Now, oxygen therapy is also required and is very important because of the respiratory distress they come with. Some also come with prolonged apneas, like they will breathe, stop for some time and breathe. Usually, it's a bit common with almost all of them, but when that baby stops breathing for a longer time, okay, after 30 seconds, 1 minute, the baby stops and is not breathing, then it should be something of worry. So you need to augment them with oxygen. Usually because they are also very small and fragile, you can't allow them to use the small effort energy they have to use to respire. So you bring them more oxygen to be able to breathe. Usually oxygen is given via facial mask. You can use a mask to cover the nose and the mouth, or a nasal cannula or an endotracheal tube. There's a specific catheter you can pass through the endotracheal area so that the baby will receive direct oxygenation. Also, there's this CPAP, continuous positive airway pressure. Here we've always used the modified one because we don't have the specific machine for delivering the oxygen through the CPAP. What this machine does is to make sure that it keeps the lung a bit open so that in between breathing, the baby's lungs will not collapse along the way, because most of them usually before 35 weeks don't have enough surfactant to keep the lungs open. Yeah, so with oxygen therapy, you should remember that it is a drug. And once it's a drug, you should carefully regulate it. Remember, when you give so much, okay, it can cause the retinopathy of prematurity I mentioned earlier. And one other thing to make the respiratory system or the respiratory tract a bit efficient for the baby is to give this evidence-based drug that is in the market now, surfactant. Once you administer surfactant, then the baby's lungs would develop much better to keep the baby, I mean, breathing by itself, just like the normal matured babies. Also, we do give caffeine citrates below 35 weeks gestation so that the caffeine will stimulate the brain to keep the baby breathing. Those who have long apneas, once you give them the caffeine citrate, and their brains are stimulated to stay awake and breathe and not to stop breathing at any point. Now, vital signs, you talk about the temperature, pulse, respiration, blood pressure. I think because in my NICU, we don't have the specific things to measure blood pressure. It wasn't captured in my slide, but blood pressure is very important because usually you would want to know their hemodynamics, and then you'll be able to manage them very well. So you add your blood pressure measurement to your temperature, pulse, respiration, then your oxygen saturations, including your blood glucose. They're always at risk of hypoglycemia, and you would need to keep an eye on that. Now, the fluid guidelines are for our prescription purposes, but just to mention, in a day, usually a preterm should start from 60 mils per kg. I mean, so if the baby is weighing zero point 0.9, you multiply that by the fluid requirement for the day. If the baby is taking breast milk either by cup and spoon or NG tube, then you can do a ratio of intravenous fluid with the breast milk that the baby is taking, so that at the end of the day, you get the adequate hydration that the baby would need for the day. So we can go. This also just yeah. So usually it's advisable to give them total parental nutrition for the very early days of their lives, especially the extreme prematures, those whose guts are not ready to take in food or to digest or absorb nutrients. So you give them total parental nutrition. And one thing is to remember is that they can't cough because the cough reflex usually is not there, swallow reflex is not there, suckle might be there but not sustained or not even there at all. Then their digestive enzymes too are not available. Usually up to 28 weeks. So after 28 weeks, that you can think about okay, this baby might have some level of enzymes to digest breast milk. So most of the times they are also in a disease state. Those that have respiratory distress syndrome, those that have the necrotizing enterocolitis, those that have GIT, gastrointestinal atresia, maybe in the development of their GIT, part of it is cut off. So maybe it can be at the also esophagus, so esophageal atresia, or it can be at the duodenal atresia, or other, disease states that can make them not ready to feed on any milk. You give them the total parenteral feed, which is commercially prepared uh, nutrition that this baby can take intravenously. Yes, so usually given by IV infusions, but once you are giving it, there are things that you should make sure that your your total parental infusion should cover. One thing is that it should be sufficient. That's why we're calculating how much to get. Okay, so the fluid should be sufficient. There should be enough calories, and there should be enough amino acids, electrolytes. We talk about the elements, chloride, sodium, potassium, and all those electrolytes in the body that is responsible for our chemical reaction. Then also vitamins. The baby will need vitamins to make sure that he gets the needed energy and stuff that is to keep it going. Now, usually complications that come with the total parental feeds. One important or one major one is sepsis. Okay, especially those that are kept on central vein catheters or peripheral catheters. The place can become, I mean, staphylococcus or all other organisms can incubate around that area and cause infections for the baby. Hyperglycemia, that is, if you're giving so much. Hypoglycemia, when you are giving less, then the baby can switch in between this. Usually, the catheters can accidentally dislodge and you cause infiltrations and all other complications that come with IV therapy. Thrombosis, clots can form and break into the veins and or the arteries, and then it can go into the system and cause issues of phlebitis, inflammation of the vein, or where the catheter has been inserted. All these are things that can happen. Usually, feeding is very important. So, for a healthy preterm or a small neonate, usually you want to do NG to feeding. You pass an NG tube and feed, or you feed by cup or bottle feeding. But in my people here, bottle feeding is a no-no. So once you come with your bottle, we encourage you to do the cup and spoon because of the hygiene and how to keep it most of the time. So we just discourage them from using it. Then breast milk. Breast, the baby can, if there's suck reflex, you can always put the baby. Then when you finish putting the baby to breast, you top up with the cup and spoon feeding. Other methods of feeding any preterm, whether low birth weight or whatever, it should be individualized. You can't lump them up and say, oh, all of you must do cup and spoon. No, you assess each baby's requirement or the strength, and then recommend which feeding method to give to that baby. Now, so when you are doing NG to feeding, you should always remember uh, if the sac reflex is not developed and there's no swallow reflex in those, that you need to do an NG2. What happens is you can leave the NG2 in one nostril for 3 to 7 days. So after 7 days, you have to change it. But when you are changing it, change it to the other one that was not having the NG2, so that the then you gradually move from your NG tube to cap and spoon or the bottle feeding as you assess and go along. Usually, we discourage formula feeds, but when it becomes necessary, especially for those mothers that are not able to lactate, and then you can start with the formula feeds and gradually still insisting on expressing breast milk, so that when you get some, you now try to take off the formula feeding. Now, you must be able to establish feeding before discharging a patient. Okay, and you can only try oral feeding for a baby if the baby is well, the baby is not having respiratory distress, and is not having lung apneas and those stuff. Okay, the baby is making suckling movements. Maybe you try to assess for suckling, and there's some level of suckling, and there's no vomiting. Okay, if the baby is vomiting and you are feeding, they can aspirate, and when they aspirate, you worsen their situation. And also the abdominal distension. When they have abdominal, it could be something of either a neck or any other GIT complication. When you feed them, then it will be an issue. Usually, when the baby is weighing around 1,500 grams, but this is a bit questionable because sometimes when you want to wait for a baby to get this weight, especially those who are giving birth 0.8, 0.7 upwards, I know it will take such years, but it's good to get up to one before you can start thinking about giving oral feeds. But it should still be complemented with the other methods of feeding while you assess your baby. Now, infections is very important. So I mentioned earlier, because of their immature immune system, they can always have infection. So the good thing is to prevent it. How do you prevent infection in newborn? So usually at our NICUs, we don't allow, much visitors there. And even if you are the mother, coming to the NICU, you must wash your hands and change your footwear before you cross a red line. So the red line is always an indication that you can't cross over. So once we strictly comply, make the relative or the caregiver comply with these instructions, you, the health worker, too, must strictly comply with hand washing before or in between every baby attendant. So baby A, once you are done with baby A, you wash your hands and then move to baby B. You don't wait and wash your hands at the end of the day. Now, you should also limit nurse to patient. At least if you have the luxury of a number of nurses, you can assign a nurse to maybe one baby or two babies for the shift, so that not all of you in the world would care for that baby. The more the hands of care, the increased risk the baby should have for infections. Then avoiding overcrowded. Your NICU should be well spaced so that you don't crowd the place and you don't allow visitors into their area to crowd the place. Procedures shouldn't take so long, and you should perform your procedures once and go. So performing procedures in bulk. Okay, if you have to check vitals and give medication, set all your trays available. Once you go, you give your medication, or you check your vitals and give your medication. Then you leave. You don't do one thing, then go, and within some few minutes you come back to do another thing. Our stethoscopes or thermometers, they should be well cleaned, and if possible, one stethoscope to one cord. Okay, every baby has a stethoscope, a thermometer, or an equipment, so that you don't cross them, to minimize the risk of infection. Usually, if it is possible, you encourage early enteral feeding instead of the NG tubes, and then the other mechanical way so that you reduce their risk of infection.
Okay, so we know how we are going through the management. This tells you if you have visited a NICU and they are telling you to go and wash your hands or remove your slippers or what your footwear. It doesn't mean because of how you are. That's why they are saying remove this or go and wash this. But it's
Yeah.
for the sake of reducing infection. So we thank you for highlighting on that aspect well for us. So we can.
Okay. So the other thing is Hello.
Yeah, yeah, I can hear you. We can
Okay.
continue.
Okay. So the problem of the thermoregulation I mentioned earlier,
Yeah.
usually is due. One of the challenges is that they have large surface body area. Someone explained it so well to me that I don't always forget. When they say something has a large surface area, what does it mean? So he said, when you cut small ball of banku to eat and you put it in the plate, and the big ball of the banku that you cut from, which one will get cold first? It's definitely the small one first, right? Yes, so the small one has large surface area than the big ball of bamboo. That's how our babies are. Those small, fragile babies have larger surface body area. And because of the large surface body area, they lose a lot of fluid very often. Okay, and because of the less subcutaneous fat I mentioned earlier, they lose, I mean, fluids, they lose temperature and everything early. So because of that, you would need to make sure that you manage hypothermia very well. Now, sometimes it could also be an indication of an underlying, issue. One is hypoglycemia. If the baby has low sugar, then the body temperature can drop. If the baby has infection, the body temperature can drop. If the baby has shock, maybe due to hypovolemia or anything, okay, septic shock, whatever, okay, the temperature too can drop. One thing I mentioned earlier is the KC, and we are coming to do the KC. So let's continue. We can continue. Okay, so this is one of our mother who delivered twins, and we try to get her to do KC with the twins at a go. So when we talk about KC, what does it mean? Formerly, it was called kangaroo mother care, but now it's kangaroo care because males too can do care. So males too can do skin to skin. Uh-huh. So we'll be looking at what it is in the practice and what are the evidence advantages. Yeah, so this gentleman happened to be one supportive husband that we admitted the mother some time ago. I think the baby now should be 3 years old, I think, yeah. So he was, so this is my NICU setting. This incubator is from my NICU. So he was very supportive.
Okay.
Yeah, very supportive in kangaroo care. So we happened to take him a picture, and then I'm proud of him because he went around with us with our public sensitization programs on radios and other stuff. So it's usually skin to skin contact between the mother and the baby or the father and the baby. Now let me add father to it. So when the baby's bare skin comes into contact with the mother or the caregiver's bare skin, then that is what we call kangaroo care. Now, so when you look at it, there are three components that are very important: warmth, breast milk, and love. Okay, so when you position the baby in the kangaroo fashion, it provides skin to skin contact, and that alone brings warmth between the uh, baby and then the caregiver. So the baby gets much warmth from the caregiver. Now, when you also put the baby in that position, the baby is able to what? Breastfeed alongside. So you get breast milk readily available for the baby. Then, once the baby is still in that position, the one who is doing the skin to skin contact with the baby, I mean, increases the love between him or her and the baby. So, kangaroo mother care care or kangaroo care is something we really advocate and push for all caregivers who happen to have preterm births to go through it, because it has very good advantages. Now, let's pay kind of recognition to the inventor of kangaroo care, Dr. Edgar Ray of Colombia. He was a pediatrician, did a research. The problems he tried to look into uh, brought him face to face with these facts that there was shortage of incubators and the impact of separating mothers from their babies, okay, because of NICU care was something that he needed to solve. So he kind of tried to get the baby closer to the mother, skin to skin, and the rest is a history of good news that we are advocating for every mother to practice now. Now, so the components of KC, these are the 5 things we always look at: nutrition, breastfeeding, positioning, how to position the baby skin to skin, support, whatever support the caregiver might need, whether from the staff or from the family, then we need to give that support. And discharge, on discharge, what are the things they should know? Okay, what the reviews that we are supposed to be doing for every baby undergoing KC, and then the follow-up care that is necessary for them so that they would grow to the max that we're looking for. So these 5 components are very important. So these are just pictures. This fine girl with a balloon, that was her birthday she was celebrating after she had gone through our NICU, and the mother picked the picture and sent to us. Now she should be around 4 years or 5 years, I think. Yeah. We can continue. Okay, so what are the benefits of kangaroo care? We're going to look at to the baby, to the mother, to the hospital, and the community at large. So to their cardiac and their respiratory stability. Once the baby is put skin to skin with the mother's heartbeat, the mother's inspiration and expression also try to influence the way the baby also heart beats and then also breathes. So it kind of stabilizes them on that scale. Fever episodes of apnea. Once the baby is always stimulated by the mother's skin, the baby will not forget to breathe. Okay, and then there's improved gastrointestinal function. There's also higher initiation and then duration of breast. At least when the baby is feeding while on skin to skin, it's the likelihood that the baby will stay for long to breastfeed is very high. And weight gain, once they are feeding well, then there is likely a higher chance of a good weight gain for that baby. Now, they are also protected against infection. So once the mother is clean and is keeping them skin to skin, usually infection is much reduced with them. Effective thermal control, emphasize much how that is done. Now, the mother herself, okay, she becomes confident in handling the baby. You know, these preterm babies are very small, and if you are not careful, it can fall off your hand. So, as the mother continues to attach the baby skin to skin, the mother gains some level of confidence to care for this baby, and there's improved bonding. That love between the baby and the mother is increased. It also empowers the parents or the mother to play an active role in the care of the baby. At the end of the day, it's not the nurses that or the doctors alone that are handling the baby, but you, the mother, even takes a greater portion of it, because once you are able to know what kangaroo care is about, then you are doing it. At the end of the day, you take more of the care. The nurse will only come when it's time to check vitals or time to give medications or other stuff. Now, enabled to become primary caregiver. So the mother understands perfectly what the baby needs. So will be able to provide for the baby even before calling the next person for help. You become their primary caregivers, and promotes breastfeeding, as I mentioned earlier. Stress reduction. Evidence suggests that when they are on skin to skin, the mother secretes more of oxytocin, and oxytocin happens to be a calming hormone, and that can reduce your level of stress as a mother. For the hospital, it will be cost saving because you don't need money to, I mean, you don't need to go and buy a lot of incubators again or radiant warmers, right? So the little that you have, you can invest it somewhere instead of looking for uh, bigger machines. And even though they are also very important because of it's not every baby that can start kids. It is less nursing staff, shorter hospital stays. So once your they do well and go home, your bed occupancy rate kind of reduce. So at the end of the day, you still have more space to admit more people, and then improve your morale and your quality of work. Others will go and recommend your hospital to other, what do you call it, people, so that they'll come in there preterm, get your answer as well. So your mortality, so everyone have less mortality. Now, to the body will be looking donation from the discharge your baby, the cost of it, and then there's complication. They are well, follow them up well in school, in cerebral palsy, no one is having the mental delays or other stuff. Then the community would be a better community to live in. So in short, these are some few advantages that we need to look at. So usually there are models of the KC. One is the continuous 24-hour. Okay, so that one you do it continuously. You can do it and sleep till you wake up the next morning. Okay, then whatever you are doing around, you can still do it. So we also have the intermittent. Okay, it's time for KC. Everybody come and do KC. So they'll all come and do for maybe an hour to two. Then you would get a baby to come out and do other things. Then also we can do the ambulatory KMC. Ambulation, once the baby is on you skin to skin, well strapped, okay, you can go around with your house chores or whatever you want to do. The baby is secured on you, just like how you back your baby around while doing things. The important thing here is that the baby is on your bare skin and is also bare skinned. Now, what do you need to do a KC? It's very simple as ABCD. The mother's cloth or your wrapper, okay. Then you need maybe a comfortable chair if you would stay, if you want to do intermittent for some time. Then maybe a bed if you are to sleep while doing the KC. And then the woman or the man should be willing, okay. It shouldn't be forced. Then you need a supporting staff. So the caregivers or the health providers should be that much supporting so that once the person is doing it and you are very supportive of them, it will encourage them to do. So this is also a group picture we took in our NICU during an intermittent KC for some of our mothers. So their own cloth that they used. Where can you do KC? In the hospital, whether in the labor ward, the neonatal wards, the postnatal wards, the well baby clinics, or follow-up clinics, or in your house, your own home, or in the community. You can do KC while you attend your community DEBA. Okay, it's possible to do it. Now, we want to look at how to prevent premature birth because we don't want them to be coming out preterm, right? Because of the issues they come out with and the complications. So, usually, one thing to do is to accelerate the intrauterine fetal lung maturation. So, how do we fasten or hasten the maturation of the fetal lung while in utero if we know that this baby will come out? We give steroids, okay. The steroids, when given antenatally, um, it helps their lung surfactants to develop early so that when they are giving birth, they don't suffer the complications of respiratory distress. Now, this evidence has reduced or has shown a reduction in mortality and morbidity rates in the preterms when they come out. And then usually it reduces the complications I mentioned earlier significantly. So there's an evidence that suggests that when you give the steroids more than 24 hours or less than 7 days before the baby is born, the likelihoods of the fetal lung maturation is very high and they come out and do very well without these complications I mentioned earlier. Okay, number two is to prevent preterm labor or delivery itself, okay, by using tocolytics. So if a mother comes with preterm labor, okay, then you can use beta-metics to stop the preterm labor, prostaglandin inhibitors or calcium channel blockers. Use any of these to, stop the premature, what do you call it, labor from growth. But there's an incident I came across one lady who is now having a cerebral palsy baby because of severe bed asphyxia. He was in preterm labor. He visited one facility. They gave, I think, one of these drugs because she couldn't recall what the drug was they administered. I asked her to go home. No, admit the mother and monitor. Don't give and say, oh, go home. If this and then you come back. Once you want to stop the preterm labor, you have to monitor to make sure that the drug has effectively worked. Now, teenage pregnancy is something that's on the banner, especially recently, now that almost everyone wants to taste the forbidden fruit. And we have thrown family planning practices like use of condom and other stuff because of other reasons best known to them. I think we should up our game on the campaign against teenage pregnancies so that we can be able to reduce preterm births and also encourage our women to give birth earlier before 35 and above. Okay, so that late delivery shouldn't also come with preterms. ANC attendance, okay, when encouraged, they learn a lot at the ANCs. So it helps them to identify early signs of preterm labor and report early so that they could be managed appropriately. Now, maternal infections are very important to prevent. I know when they come for ANC, there's always some labs they ask them to do. So once they're able to get some of these signs of infections earlier and they treat them appropriately, then it can reduce the menace of preterm delivery. Our discharge criteria is very important because usually these babies tend to stay very long in the NICUs, especially those that come with a lot of issues. So one thing I always encourage is that once you've admitted the baby, and you know that there are a lot of issues to be dealt with, start psyching the mother's mind as to how long they may be expected to stay in the hospital because it helps them also to plan ahead and not come to cry on you that, oh, we want to go, we are tired, our money is finished. Egamelio, where we are coming from, Egamelio is an anthem. Okay, so usually we want to be sure that the infant is feeding very well, okay, whether by cup and spoon or on the breast before you can even contemplate about discharging. So when the baby is feeding well, there is steady weight gain, usually less for babies that are less than 1.8 kg. You should make sure that at least the baby is gaining the weight steadily every day. So it means that you should be doing daily weight monitoring for your preterm babies or alternate day weighing so that you'll be able to know that this baby is gaining weight. Then stable temperature for a period more than 48 hours. Okay, the baby should have temperatures within the normal range that I mentioned earlier, 36.5 to 37 or 37.5. The baby should stay within these temperature ranges. Then there's no recent apneic attack. The baby has not recently forgotten to breathe. Okay, so all these are bad. No infections, no anemia, and other stuff. Then home settings should be ready to receive baby. We've discharged one preterm baby and they've stayed for 2 months again because the home is not ready to receive the mother. Actually, where she came from is not actually a place that she should go back. So we had to looking at how to liaise with other institutions to see how best we can get the baby cared for while at home. So they stay with us just because the home is not ready. So what will show that a home is ready? Fine, there is a supporting family, okay, and the mother when at home can still continue some of the teachings, the KC and other stuff that you've spoken or you've taken the mother through while they were on admission. And financially, or there's someone who can still come with them for follow-up or to be able to come for the needed follow-ups or the KC reviews that are necessary to follow up on this baby. Okay, we can continue. Also, once you have cared for this baby and discharged the baby, it doesn't end from there. You need to follow up. So, what are the subsequent care? Usually, you would want to advise and start on routine immunization. They will also go through all the weighing or the child welfare clinics that are necessary for every baby. So they should have regular schedules. They should be able to get the standard doses of each of the vaccines that every child should have. Then you need to assess their hearing and their sight. So what happens is here, once we discharge you, we have a good eye clinic. So we try to get you to the eye clinic for assessment. Okay, once you come for our follow-up reviews, we still let you go for assessment. So it's ongoing till a year or more. When the baby is okay, then we graduate you. Also, hearing, we don't have a good ENT this thing now, but I think it's something that we will be looking at moving forward. And your KC reviews, kangaroo care, you come, you measure the anthropometries, you weigh, and then you still reinforce the teachings and get the mother to do some of the things that while on admission she was doing for you to be sure that it's still ongoing at home as well. So subsequent care is also very important in the lives of these little ones. Now, when they are discharged, there are still other problems that can come. And some of them are the long-term problems I mentioned earlier. But remember, when you look at their weight, some can still be thinner or smaller than every normal birth. Okay. And so you don't compare them. Oh, this baby at age this was supposed to be weighing this, but it's still not weighing that. Please have a bit of patience for them. But when it is something that has deviated so much in the standard deviation charts, then you would need to act promptly so that you prevent any complications that will come. Now, they have increased risk for readmission. We said all their systems are not mature. They had issues while at birth. Those issues, some can be resurfaced. So you would need to constantly follow them up. Wheezing because of the bronchopulmonary dysplasia. And then neurological issues, visual hearing, motor learning, language problems. So you would see some of them have issues with aspects of their developmental milestones. Some could be global, so you have to still follow up to know. So our success story, our twins that were doing KC. See the mother in her swag says, okay, a happy mother and then two babies smiling. We also, I mentioned earlier, this baby that was celebrating the 1 year that the mother took a picture for us. Um, these are more of them. I think this guy had a lot of respiratory issues, was on oxygen for more than 2 weeks. Now he's a scholar. He's doing very well in school. Okay, so this guy too. I think this girl at my right side, it was I think 27 or 28 weeks. But now she's doing well. The mother traveled, so it's been a year we've not met her around again. Okay, so what's our challenges? So this one is just to anyone who is listening to us. As Brajo said earlier, maybe after this, you might want to come to our aid in any way. We don't have enough equipment. It's just a small area, but we are doing the best we can to make sure that our babies survive. When necessary, we refer, but we don't have much phototherapy. I mentioned earlier that jaundice is one of the problems they come with, and you would need to do phototherapy for them. And sometimes we have two phototherapy machines, so you have a lot of babies doing alternate phototherapy, and some you just have to refer because you don't have enough space for them because of jaundice. So I think if we get more phototherapy machines, it will be of good help. Incubators, the CPAP machines I mentioned earlier. Our goal is to get a ventilator because sometimes we have those babies that need to be ventilated, and because we don't have such a resource, usually we have to, send out. And perfusers, once the babies are to be taking smaller doses of drugs, you will definitely have to be giving volumes in smaller quantity over a period of time, which the perfusers are very helpful in that direction. We have dosiflows though, but usually we want much of accuracy in our treatment. Now, family patient cooperation during care, I think this one is in-house. Usually you would have to counsel and counsel and counsel again. So we want to encourage our parents, anyone listening to us, fine, we don't usually just want to unnecessarily detain you, but because we want the babies to do well, and when you go home, you don't have future problems. That's why we would want you to cooperate with us. Now, cost of care, because of the prolonged stay, some of them they are not able to settle some of the few bills that they generate, especially oxygen. I mean, the cost of oxygen therapy and other stuff. So maybe sometime when you have philanthropists passing through to help settle some of these things, it helps the facility to also keep running. Then our IPC measures, which we are always tough on ourselves, and even though some of the relatives will not understand why their woman has delivered and say you can't go and see the baby. But we're trying to manage to counsel and then to get the education down to them so that when they face some of these issues, it's not because of them, but it's because of the babies that we also love and care for. Yeah, so we're calling for support, phototherapists, CPAPs, any other thing that you can help us with, so that we'll give the best of care we have. Who knows? It might be your relative or whoever that will be coming to Margaret Makwa Hospital someday for care, and we might have to pass through the NICU and would need to use any of these machines. If it's available, we'll gladly and professionally handle such a situation for you. I think.
Thank you, thank you, thank you, thank you, Mr. Anaba. Ritual media health issues. Our viewers and our listeners can't stop thanking you. Sister Christiana Sapon said, watching you live from Amsterdam. Then Sister Felicia said, thank you for this presentation. A lot has been learned. Then Sister Josephine also said that this topic is very educative. There is hope for preterm babies. Yes, as we are sharing the success stories, there is hope. We are always thanking you for the presentation. We know you are very busy, but having time, spending your precious time with our viewers and our listeners in this World Prematurity Day is something that you have sacrificed. And there is a question that came before you answer that. It says that you mentioned about the thermal regulation. Can we also use rubber Macintosh to wrap the baby when transferring the person to a referral center? Thank you.
Okay, thank you for the question. I think once the rubber Macintosh is set softer to be able to uh, cover any surface area of the baby. I remember those days that we had this leather Macintosh. It's always a bit hard to deal with, but if you have a soft rubber Macintosh, as you said, and it can securely cover the baby. The fact is that we don't want air to be passing through while you are transporting. So once you are able to secure this baby with this Macintosh rubber, it is fair to go with. We just want to make sure that the babies are kept warm till they reach where they are supposed to be received.
Okay, thank you. So, Mr. John Anaba is a specialist in this field, and he is working at Margaret Marquardt Catholic Hospital in Ghana. The region is Volta. Mr. Anaba, in case Richmond Media viewer or listener want to support or assist with small or little that they can help with the challenges that you have mentioned, how can the person reach out to you? We know our viewers and our listeners want to also hear that from your mouth. Thank
Okay, thank you very much to Richard Media and then the team and all well wishes for giving an opportunity for me. As you mentioned earlier, I'm John and I'm a nurse specialist, pediatrics for that matter. And I have a telephone number I can give out in case you want to support. Also, you can look up our hospital Facebook page is Margaret Marquardt Catholic Hospital. We have an email. You can email our managers if you want to pass through management. But if you want to, I mean, the hospital email is info.mmch1960 at gmail.com. info.mmch1960 at gmail.com. So you can email, and any of the managers who have access to the email can reply you. But if you want to contact me personally, then 0246 918098. 0246 918098. That's my personal line, my
you. So
personal
because it's
email.
in Ghana, the code should come.
Yeah, yeah. So
So it will be plus
yeah.
233.
Yeah, so you add +233 if you call in outside Ghana, +233 246918098.
Okay. Thank you,
And
Mr.
we'll be
Anaba.
glad to get you supported.
Yeah, we are hoping that our viewers, our listeners, Richmond Media team, everywhere will also help in these challenges as you have mentioned. And we are hoping that it will come, the support will keep coming. Because once we have some of these things, it can help us to save most of these children. God bless you, Mr. Anaba, for your time. God bless Richmond Media viewers. God bless Richmond Media listeners, and God bless us all. So, Mr. Anaba, we want to end. Any message for us before we end today's class? Thank you.
Yeah, so as I said earlier, I was really happy when I had the invitation from Richmond Media to present today. And I hope to make time some other day or other time when the opportunity comes again. And also to extend some greetings to every other person listening to us, especially some of my colleagues and friends who are currently outside, and I think I heard one of them their names. So we just want to greet you and say we are also here doing the little weekend. So however way you can support us to continue the care that we need to care for, then kindly do that. And also to all preterm babies, today is their birthday.
Oh,
If I could go outside into my NICU, I would have showed you how we've decorated our balloons to celebrate them. The event is tomorrow. We will have some mothers passing through to give testimonies about how their NICU experience was caring for a preterm baby and how they are doing now. And at the end of the day, it helps us to increase the advocacy and the awareness that we need everybody to come on board about. Thank you for the opportunity once again. And thanks to Richmond Media once again for allowing me to be part of you today.
You are welcome, and happy birthday to you and the Niku team also, and the preterm babies and their mothers. Happy birthday to you all. So we know, as part of our birthday gift, Richmond Media viewers and listeners will also support as part of birthday gift, and we know
Thank
that
you.
will come. So God
Thank
bless us all. Until then, same time next week, we will bring health issues to your doorsteps. Thank you, and good evening.